Thank you very much, everybody. I hope you don't have a post-lunch lull because I've got a lot to live up to today after all this scientific information spouted at us. I felt a bit overwhelmed, but I felt better off that, so I'm going to let you just take in all the information that I have today. As probably those of you who do know Parkinson's or work in Parkinson's or have seen patients who've got Parkinson's are aware there's very, very little research or RCTs published on dietary management in Parkinson's. So this is very much what the evidence is about and how we can put it into clinical practice. Firstly, thank you very much to Nikki and to Nestle for inviting me to come along today as well, and to Anton for that lovely introduction. A bit of pressure on me now. So basically, I've been asked, my remit is to talk about the dietary management of GI dysfunction and Parkinson's. Now, before I came today, I know I work in a centre of excellence. I've been working at the National for coming up to my 17th year. And I see a variety of neuro patients, neuro conditions, and Parkinson's is just one particular area that I have a passion for. And I don't often get very much time to do CPD and research the literature. So again, thank you to Nestle and to Nikki for giving me this opportunity to improve my CPD and obviously be able to improve the care that we give our patients at the National and to my colleagues at other sites. Okay, so the outline for this afternoon. Luckily, I've got quite a lot of time, so if I do go off on a tangent, plenty of time to do that. So what we're going to talk about, I can't start a presentation without actually going through the particular condition as well, because a lot of you may have heard of Parkinson's disease, but actually may not have had the chance to be able to understand what it is, how it occurs, etc. Also, there's different stages of Parkinson's disease. It's not just one stage, it's not just one thing. So we'll go through that as well. Looking at symptoms, so you've got motor and non-motor symptoms, and we'll go through that as well and define those. What are the available treatments now currently available to our patients? Looking at GI dysfunction, because that's my remit for today. Looking at the dietary management for each of those GI conditions, and to take home messages, and I put up questions and references. So what is Parkinson's disease? So it's a chronic neurodegenerative disease. It was first described in 1817 by James Parkinson, who was a surgeon in London. And he wrote an essay describing 6 patients that he had seen, 6 people he had seen walking down the street. He hadn't actually assessed these patients or people. So what is it? It's basically an impairment of the dopamine-producing neurons in the striatum nigra. This is the normal substantia nigra, so you've got your dopamine cells here, and this is what happens in Parkinson's, so you're losing your dopamine. And what is the function of dopamine? Well, it produces smooth, purposeful movements and other non-motor activities. So there's different stages, as I mentioned. So we have Margaret Hone and Melvin Yarr, who described the scale called the Hone and Yarr scale. And it goes through different stages. There's 5 stages to Parkinson's disease. However, this actual scale has been updated more recently. So there are little stages from each stage as well, particularly in the latter stages, so from stages 3 to 5. So in stage 1, that's when you've got mild symptoms. So for example, tremor or shaking. Stage 2 is where you've got symptoms that are bilateral, so you've got both limbs are involved. Stage 3, where you've got slowing in your physical movements, becoming quite stiff. And then when it comes to stage 4, that's when you're seeing more severe symptoms, so symptoms like rigidity and bradykinesia, and I'll describe them later. And then end stage. Unfortunately, this is pretty bad stage. This is when you're quite severely disabled, where you're needing one-to-one care, or you may be ending up in nursing homes or care establishments, and you will need assistance with all your ADLs. So what are the motor symptoms? So we've got tremor at rest. So basically it's where you see a patient's limbs starting to tremor. Rigidity, so some carers describe if they ask their loved one to raise their arm, that it's very much like a cogwheel, so it's akinesia, again, slowing of movement, also known as bradykinesia in some of the literature as well, and postural instability, and that's where you end up then with a lot of falls, a lot of drops, and this is what some of you might find with some of your patients, this is what their gait looks like. So you've got a mask-like face, also known as hypomimia. So there's no particular expression, they're completely pan like that. You've got rigidity and trembling of the head. They've got a forward tilt, so they're moving forward. Reduced arm swinging, rigidity and trembling in the extremities, and a shuffling gait. So I don't know if you've had any experience when you hear your patient going ch-ch-ch, and you think, drag your feet, just keep dragging your feet. Especially, it makes a lot of noise when they're wearing slippers on the wards. Okay, so the non-motor symptoms, which are not involved in movement at all. And the list that I'm going to show you is non-exhaustive, okay? So I'm just covering some of the terms that are used in references in scientific papers. Anxiety, depression, pain. And for the purposes of today's presentation is GI dysfunction. And the 4 different areas I'm going to cover are dysphagia, gastroparesis, small intestinal bacterial overgrowth, and constipation. This is just a picture of what patients have reported, that people they meet on the street just see the tremor. Actually, there's a lot more going on underneath the surface. So what are the available treatments? We talk about medication. So levodopa has been around since the 1960s and is a predominant treatment. And some of you might have seen in some of your patients' drug charts as well that you've got Sinemet, Stavilo, which is a newer drug, Duodopa, which can be given via the PEG-J route, and Madopar. And these are just some of the pictures of that. So you can see the Duodopa being given, or the apomorph, is it Duodopa? Yeah. And then you have, in the 1970s, you had the MAOB inhibitors. And then 1980s, 90s, and 2000s dopamine agonists. And I'm not going to go into the background information about these, but these are just something for you to be aware of. There's your apomorphine down in the right-hand side corner, COMT inhibitors, glutamate antagonists, and anticholinergics. So there's quite a lot of medication that is being used. And just to be aware that your patients can be on levodopa, Sinemet 10 times a day, multiple times. So it does have an impact on appetite, nausea, and nutrition. So who's involved from a therapy's point of view? So for patients who are living with Parkinson's disease, we have the dietitian, physiotherapist, OT, and the speech and language therapist. Again, this list is not exhaustive, but just to let you know, for I work, I'm very, very lucky to have these members of the team involved in our patients' care. And I do pull on their knowledge and their expertise on a very fairly regular basis, and I do not work in isolation. So apart from medication as a treatment, there's also surgery available. DBS represents deep brain stimulation. It looks like this. And it's where you have wires implanted into the substantia nigra. And it's connected to a generator, which then delivers frequencies to the substantia nigra, stimulates, and it won't stop Parkinson's from progressing. So even though you do have DBS, this type of surgery, you will highly likely have to carry on with the medication treatment. Not everybody can have this particular surgery. It's for mainly those where their local commissioning group says yes, because it actually costs in excess of £20,000. And they would compare that to actually their medication treatment, which can be about £3,000 a year. And it's not going to cure your Parkinson's. It will not stop the progression, and it's not a cure. So, on to gastrointestinal dysfunction. So what we're doing is going to talk about basically from the mouth, so from the oral cavity, right down to the rectum. So, dysphagia. So some numbers for you today. So about 80,000 people who are living with Parkinson's disease have dysphagia, and there's about 50% of those who actually have no signs of that, so they're asymptomatic. Now this is old, this 2001 reference. It was found that the length of time from when somebody is starting to display symptoms of Parkinson's, that they become dysphagic within about 10.8 years. Well, actually, because there's been quite a lot of developments with treatments and with medications, this particular length of time may be different. But for the purpose of today, I actually went on PubMed, I went on loads of search engines to try and find out if any other paper could give me an up-to-date timeline, and I couldn't find any. But if anybody else knows, I'd really appreciate that. You can get in contact with me. So what sites are affected in Parkinson's? So the oropharyngeal, so from the oral cavity and the pharynx, and this is where a lot of our speech therapists find that this is the first symptom of dysphagia in Parkinson's is found. And esophageal, so the esophagus and the right down to the stomach. And the symptoms are, again, not exhaustive, gurgling, wet voice, choking. Some patients have nasal regurgitation, which is quite distressing to them. Again, unable to manage the boluses of food in their mouths, so they're pocketing food in their cheeks, at the back. Food is drooling out of their mouths, water is dripping out. And the consequences of that is aspiration. There's quite an increased risk of aspiration, and pneumonia is one of the commonly reported causes of death. I'm sorry, death is very small. I think something happened there. It's something that sometimes is overlooked as well. So a lot of the papers are advising and guidelines are advising that we need to be reviewing this regularly with tools. Weight loss and dehydration goes in line with that. And also patients have been shown to have increased risk of gastroesophageal reflux. So how do we manage? So a lot of MDT working. Again, for the purpose of today, it's about salt and dietitian, but obviously we've got OTs and physiotherapists who can help us as well. So what kind of swallowing strategies? So a lot of our speech therapists advise a chin tuck and multiple swallows. Again, it's not for everybody, and these patients are all individuals, so they get individual strategies. Texture modified diets, so anywhere from puree, soft, and obviously fortification as well. Thickening agents are maybe used as well if your patients require thickened fluids. So there's a range of powders that you can use that, or also there's pre-thickened oral nutrition support products, so desserts and drinks. And I put gastrostomy at the very end because we don't usually routinely peg or put in gastrostomies in our Parkinson's patients. Usually it's when they're near the end stage. But some of our patients you might find, whether it's in the community or if they come in as an acute case into your local general, they may have a PEG-J already inserted where they're getting duodopa. So in that case, that's where I always kind of use what I've got in front of me, and if they do need nutrition support, for example, during a period of aspiration and they're trying to recover, I will use the gastric port to administer enteral feeds. It's important to note as well, if anybody has had experience with duodopa, that we aren't advising anybody to be fed through the PEG-J during the day, and the reason for that is because it'll interact with the duodopa. It's an intestinal gel, it's administered over a 12-hour period during the day. And obviously, we then use the night time for giving the feed through the gastric port. Okay. And it's always very good to know from a very, very start in the patient's journey is what are their thoughts about PEG feeding in the future as well, so we can have that documented and also be aware of any advanced directives as well that might be in place in case the patient decided they didn't want that at the end. So gastroparesis, now this is a new thing. There's lots of more new literature coming out looking at the incidence of gastroparesis and Parkinson's. Now, I updated the Manual of Dietetics, the Parkinson's section recently, and I never thought about putting this in the manual because I wasn't aware. And again, that comes down to the fact that I didn't see that many patients coming in with gastroparesis with Parkinson's, but I don't know whether it's something to do with Anton coming to the national, because I'm seeing more and more gastroparesis, but for a good reason. So again, an opportunity today to look at some research. So it's very new to me, but I spoke to the Parkinson's team this week, and I said, do you know, we had patients coming into clinic, coming in onto the wards, complaining of the same symptoms, and I was always put down to, it's their anxiety, no, it's their depression, no, it's medication, no, it's a woman, she's going through the menopause. But actually, their symptoms very much mirror the symptoms of gastroparesis and other. I'm not saying it's all gastroparesis. So it's impaired gastric emptying, and that's due to autonomic failure. And the papers show it occurs in 70% of our patient group. The symptoms, abdominal distension, bloating, nausea, vomiting, early satiety, diarrhea, and constipation. So what are the consequences of that? Well, if you've got somebody who's on levodopa 10 times a day, got gastroparesis, they're vomiting that up on a daily basis, we're going to have very little absorption. So again, their symptoms are going to worsen. And it takes about 60 to 90 minutes for the levodopa to degrade as soon as you ingest it. So it's very important that there's no delay or no problems in the way for it to get down to the ileum. Again, if you've got gastroparesis, it goes without saying, nausea and vomiting, not able to keep down enough food or fluid, you're going to end up with unintentional weight loss, dehydration, and electrolyte imbalance. And that's something that we will be discussing, you'll see it be highlighted in the case study in a little while. So what the critical factors are for normal gastric emptying is normal intestinal function is gastric emptying and transit via the pyloric sphincter. So how do we manage it? So basically the outcome is to focus on maintaining or improving nutritional status. And how do we do that? So what we're trying to do is we're trying to reduce the symptoms that the patients are having. And again, you might have patients who are just vomiting, or they've got ongoing nausea, diarrhea, early satiety, bloating, and pain. So what we need to do is correct their fluid and their electrolyte and nutritional deficiencies. And it goes without saying that a lot of our patients who've got Parkinson's disease do have comorbidities, and one of those can be diabetes. Right, so the PPH, ignore that for a moment. So if you've got somebody who's got gastroparesis, the literature does suggest that small, frequent meals are of benefit, and one particular professor has described about an egg size is what you're looking at. Don't know where he's got that from, an egg size. But also that when you've got gastroparesis, that the stomach can empty 1 to 2 calories per minute versus normal gastric emptying, which can be anywhere up to 4.5 calories per minute. So we look at a low-fat diet, a low-fibre diet, and again, that goes without saying. So if you've got a high-fat and a high-fibre diet, it's going to stay in the stomach for longer. Modify the texture of foods. This was new to me. You make sure that the patients chew their food really well, so it's really well masticated, or offer them a puree diet. And that again has been shown to empty from the stomach a lot more quickly than somebody who has undigested food or unmasticated food. So what we do is, in conjunction with oral diet, we would use meal replacement drinks, so anywhere from your powdered ONS that you can make up yourselves, or the ready-to-drink versions. And also varying the forms of the food, so you might find in the morning that they're able to eat a more solid meal, but during the day, as the day goes by, that you might find that actually they're very satiated, they're feeling very full, very bloated. You might want to consider having fluids, nourishing fluids for the rest of the day. But again, the information I'm giving you today will vary with each of your patients, so just keep that in mind. And alcohol and smoking has been shown to decrease your gastric emptying as well. Enteral feeding, if it is needed, standard polymeric feed, and we have used more recently as well, and in the case study as well, a 2 cal per mil, where you can feed a smaller volume throughout the day, each per hour throughout the day. Now, postprandial hypertension scares the wits out of me. So you'll find that these patients who have got Parkinson's disease might have gastroparesis, but they might have postprandial hypertension. And that's where there's a rush of blood to the stomach, which can cause lightheadedness, dizziness, and a low blood pressure. And the consequences of that are falls. I don't know if anybody's heard of that before, where your poor patients had a meal, sat down, had a meal, got up very quickly and collapsed straight away. So that's your PPH. So the dietary strategies for PPH are quite similar to gastroparesis. So that's why I've highlighted it with PPH. In postprandial hypertension, there's evidence to show that if you were to have 500 mils of water on waking, so you get the patient to sit up in bed and you get them to drink 500 mils, is a lot, especially for Parkinson's patients who really struggle with fluid, that it actually helps to get their BP up, so it's safe for them to get up and mobilise to the toilet in the morning, to get dressed, get washed. Look at low carbohydrate meals, so there isn't an immediate rush to the stomach, of blood to the stomach and away from the brain. Increase salty foods as well, so it kind of goes against high blood pressure advice, so that way. And again, there's not a lot of evidence out there. There's no randomized controlled trials to base this evidence on, but a lot of it's been clinical experience and working with the autonomic team at the National as well. Reducing caffeine. And this particular group of patients, if they do have postprandial hypertension, are unable to tolerate your standard oral nutrition support drinks and desserts because of the sugar content in them, the carbohydrate content. So we find that they are only able to manage the one-shot style of nutrition support. And also, overnight gastrostomy has been supported as well. Again, this is based on a case study that the patient actually I was involved with, and Professor Matthias at Queen Square presented this, that this patient actually had swallowing difficulties as well. And what we did is we administered feeding overnight, and by the time they woke up in the morning, their parameters were a lot better. So they didn't have lightheadedness, they felt really good, their BP was really good. Okay, so what's the criteria for initiating enteral nutrition supplementation in gastroparesis? If we talk about the routes first, so NJ, post-pyloric, is the best way, and then leading on to PEG-J for those whose condition is going to get worse and there's no coming back, or TPN. So in those patients who've got severe weight loss, it's unintentional over a 3 to 6 month period of 5 to 10%. Repeated hospitalizations, which you'll note in our case study as well, is where they have unmanageable gastroparesis and they need IV hydration and medication. For those patients who you're trying to set like a goal weight and they're not able to achieve it and they continue losing weight, and and also patients who require venting as well. So it's where you can aspirate off the excess gastric fluid in the stomach to kind of like reduce the nausea and the vomiting and the bloating that the patients suffer from. It's also another route to absorb your medication. So if you've got somebody who's got Parkinson's, they can't get them to absorb their levodopa, then if we put an NJ or a PEG-J, we've got another route to get directly into the ileum. So also for patients, again, who maintain usual body weight, but their clinical manifestations are pretty bad. If they've got cyclical nausea and vomiting, which we'll find in our case study as well. And if they've got overall poor quality of life, that's when we would consider using enteral nutrition support. So now this one has thrown me, this is really good, because again, there's more evidence coming out to show that a lot of our Parkinson's patients actually have the small intestinal bowel overgrowth, bacterial overgrowth. It's characterized, I think I've missed a word on that slide actually. It's characterized by an increased number of normal or abnormal bacteria in the small bowel. And its prevalence is in patients who've got gastroparesis, and it's been shown to be the cause of about 84% of gastroparesis. And you can tell me if I'm right or wrong later, Anton. And those who've got motility disorders, and it's also been found in 30% of Parkinson's patients as well. And that is from the 2017 reference that I've got up there. Symptoms of this is very, very like IBS. So bloating, diarrhea, constipation, malabsorption, weight loss, and then the consequences of that is malnutrition. So how do we do this? So hydrogen and methane breath tests. I believe the gold standard is jejunal aspirates. I'm not a gastroenterologist, so I'm not too sure. You're getting the nod. Yeah, okay. So it's been shown that if you've positive hydrogen test, it means you're more likely to have diarrhea. And if you've got a positive methane test, you're more likely to have constipation. And the consequences of SIBO is malnutrition, weight loss, nutrient deficiencies, and worsening motor function as well. So how do we manage it? Nutrition support. So we need to treat malnutrition, and that's in the case where you've got patients who've got malabsorption and got lots of diarrhea. Again, these patients need individualized care. So some might need a lactose-free diet. Some patients might need artificial nutrition supports, and again, we've used polymeric feeds. Occasionally MCT oils, for example, coconut oil, or your partially hydrolyzed or semi-elemental peptide feeds. There's not a lot of research out in using those in Parkinson's patients with this condition. So it's basically based on patients who've got no Parkinson's. Again, there's evidence to show more, this is fantastic, on the use of prebiotics and probiotics as well. But the studies are limited in this particular condition, again, because the concerns about having lactose in it and FOS. And a recent study at UCL back in 2015, well, it was published in 2015, was a pharmacologist who did in vivo tests looking at your liquid probiotics that are on the market currently, and looked at the freeze-dried versions. And what they did is they used pig gastric juices, fluids, in the fasted state, and gastric juices from pigs in the non-fasted state, the fed state. And what they found was that the liquid versions actually survived the gastric pH a lot better than the freeze-dried versions. But they said because it's been done in vivo, so in lab conditions, that there's more research needed in humans. And if in doubt, I would not be managing these patients unless I was speaking to somebody who deals with low FODMAP diets as well, because they are a wealth of knowledge And I would advise you to definitely, if you've exhausted all interventions with these particular patients, a FODMAP, a dietitian in your local area is a definite asset. So how do you prevent the recurrence of this? So again, the advice is that you need to space their meals out to every 3 to 5 hours. And also has been noted that getting psychological input as well to help manage their stress. So constipation. So I'm going to look around the room, and I'm sure I'm going to get lots of nods, and I'm going to hear that, yeah, actually, a lot of your patients, one of their problems is constipation and how it impacts on the quality of their life, eating and drinking on a daily basis. And it can take over the consultation as well. So there are so many definitions. When I was looking at the research, it's like when I was looking, there's over 10 definitions of what constipation was in the PD literature. So it can be anything where actually the patients are using laxatives. So that's their definition of constipation. A complete bowel movement or non-complete bowel movement, slow transit, less than 1 bowel movement per every 3 days, 2 bowel movements per week, etc. So it was a little bit difficult to try and read through that. But for the purposes of today, it's been reported in at least 90% of patients living with Parkinson's disease. So it's a valid cause for concern for them. And as you see the patients declining as the years go by, it does get a lot worse. And then again, that's been done in a study recently in 2017, just published. And I don't know if you've been looking at the news recently as well about, again, and we were just talking about this morning about whether constipation may actually occur before the patient's diagnosed with Parkinson's disease as well. But I don't want you to rush out and start getting your probiotics and laxatives and high fibre diet just now. So again, we're just waiting to see for more information and research. Okay, and this particular one, the Knudsen found that their particular patient group that they studied, that about 80% of the patients had a long colonic transit time, and about 66% of the patients had significantly increased colonic volume. Now, this statement, increased occurrence in those in dopamine agonists versus levodopa. Now, I was speaking to my Parkinson's team recently, and they were saying, but you know what, there's so many other things going on. I don't think it's just the medication, it's everything else that's going on. It's looking at, nutritional types of medication they're on, anxiety, etc. So I'm not too sure that this is something, this is what was in the literature as well, has been increasingly coming up. So how do we manage it? Okay, so, you need to find out from them what are they eating at the moment. So the aim of it is to promote appropriate stool consistency and to maintain a balanced diet for health as well in general. So the objectives: establish what they're eating and drinking at the moment, how much fibre they're having, how much fluid they're having. Looking at any kind of factors that may affect the transit times and stool consistency as well. Advise them how to change their diet to alter their stool if appropriate. So they could be have a lot of diarrhea. Well, you want to be able to bulk that up, or if it's very, very hard stool, you want to try and soften that. So again, we need 30 grams of fibre a day in general population. A lot of papers show that actually Parkinson's patients only achieve about 50% of that. So looking at insoluble fibre, soluble fibre, and then looking at some partialized hydrolyzed guar gum supplements that are on the market, or some fibre containing oral nutrition support as well, and the use of enteral feeds. Fluids, again, we try to aim for between 1.5 and 2 litres a day. Again, research has come out, I think it was 2016, and they were looking at a group of Parkinson's patients. Again, they're only managing on average between 1 and 1.1 litres in that particular group of patients. So actually trying to get them to increase their fluid is really, really difficult. And that's where you might need to use your PEG as maybe managing the fluid, if anything, and being a bit proactive in that way. I wouldn't advise anybody to increase their fibre intake if they're not able to meet the 1.5 to 2 litres of fluid a day, because again, you know what will happen there. It'll just make things a lot worse. So we advocate the use of prune juice and orange with bits quite a lot in clinic. So again, 2016 has been a very good year for Parkinson's and nutritional research and the use of probiotics and prebiotics. It's really good because, again, I met with the Parkinson's clinical nurse specialist on Tuesday, and she says, you know what, I've been talking to my team about this for years, that we should be having all our Parkinson's patients who are complaining of IBS or constipation, they should be on probiotics because I take them twice a day. And I said, well, you know what, listen to this. There is information out there. So basically, a paper by Kasani in 2011 looked at LKCI, Shirota, and they looked at their particular patients and they got them to take them on a daily basis over a 4-week period. And they had improved stool type. So again, it wasn't too hard, it wasn't too soft. The bloating improved, the abdominal pain was less frequent, and they had improved sensation of incomplete emptying of their bowels as well, because a lot of our patients will say, oh, I do open my bowels every day, but I never get that sense that I'm completely empty. But in this particular study, they had successful emptying. And then Baricella, RCT. Again, they were looking at the efficacy of probiotics and prebiotics in patients with Parkinson's and constipation. It's the first of its kind, and I'm very, very pleased because it kind of mimics the kind of patients that I see at the National. It was a tertiary setting, it was randomised, and there was a double-blind placebo-controlled trial. And it didn't have large numbers, but 120, really good. And what they did is they used a probiotic strain that had prebiotic fibre in it, and their placebo then was fermented fibre-free milk. And looking at the two groups, they were actually very well balanced in the stages of their disease, males to females, and the average age and weight. And they gave one of these particular drinks in the morning for 4 weeks, and they found that there was improved constipation, kind of resolving of constipation and complete bowel movement. So it's food for thought. So the take-home messages from today are: PD is a chronic neurodegenerative disease. Prolonged feeding and fatigue due to dysphagia can have an impact on meal interruption and poor oral intake. GI dysfunction may affect quality of life, treatment optimization and nutritional balance. Dysphagia and gastrointestinal dysfunction will contribute to weight loss due to reduced energy intake in more advanced disease patients. And GI dysfunction is found, frequently in patients with Parkinson's disease, so just don't discount their symptoms or reporting of symptoms as well, because historically it was very much, oh, it's okay, they're fine, it's all anxiety, depression, because there is evidence out there. The thing I'd like to make aware is that it's very difficult to kind of come up here today and give you all, this is how we need to manage our patients. But a lot of the papers are saying, there's not enough RCTs. There's no dietetic-led Parkinson's and, nutrition studies out there. We've got these patients have got so much information that they can give us. So, if anybody's interested in kind of like doing case studies or presenting case studies, getting in contact with me about anything they've done locally as well, something that we could perhaps take to the National and help out as well, because we've got patients on our doorstep. And just monitor your patients regularly. Okay, because a lot of our patients we don't see from 1 year to the next, but I think because this GI dysfunction is coming into the forefront, I think a lot of our teams are kind of taking note and hopefully shape the way we see our patients and review them.